Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 477 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. In this video we will discuss the case of patient KTM from part 476 of this pharmacotherapy series. An order is written to begin filgrastim on day positive 5 and to continue administration until the absolute neutrophil count has recovered to 500 per microliter for 2 consecutive days. Is this therapy appropriate for KTM? The use of hematopoietic growth factors after infusion of allogeneic peripheral blood progenitor cell is controversial and is not recommended by ASCO guidelines. Administration of hematopoietic growth factors after allogeneic graft infusion decreases the duration of neutropenia, but has not been demonstrated to decrease cost, length of hospitalization, or antibiotic use. Hematopoietic growth factor administration may increase the incidence of severe graft versus host disease and lower survival. KTM is receiving an allogeneic peripheral blood progenitor cell graft and thus should not receive filgrastim. KTM's pre-transplantation admission laboratory values are within normal limits. Her weight on admission is 80 kilograms. During the first 5 days after marrow infusion, KTM's weight begins to increase by approximately 0.5 kg per day. Her inputs exceed her outputs by about 500 to 1000 milliliters per day, and she is mildly febrile with an axillary temperature of 38 degrees Celsius. Blood and urine cultures are all negative. On day positive 6, her weight is 85 kilograms. Laboratory values on day positive 7 are significant for the following: a total bilirubin of 1.5 mg per deciliter, an aspartate aminotransferase (AST) of 40 units per liter, and an alkaline phosphatase of 120 units per liter. By day positive 10, KTM is complaining of mid-epigastric, right upper quadrant pain, and a liver that is tender to palpation. During the next few days, KTM begins to look icteric. Her liver function tests continue to rise slowly, until day positive 18 when they reach the following peak values: a total bilirubin of 5 mg per deciliter, an AST of 150 units per liter, an alkaline phosphatase of 180 units per liter. On day positive 18, KTM's weight is 90 kilograms. Rule out sinusoidal obstruction syndrome, abbreviated as SOS of the liver, is included on her problem list in the medical record. What is sinusoidal obstruction syndrome? Sinusoidal obstructive syndrome, abbreviated as SOS, formerly known as veno-occlusive disease, is a syndrome consisting of fluid retention, right upper quadrant pain, and hyperbilirubinemia. In severe cases, it results in renal failure, encephalopathy, multi-organ failure, and ultimately may result in death. The incidence of sinusoidal obstructive syndrome or veno-occlusive disease varies depending on the definition used to diagnose the syndrome. However, it is most commonly associated with high-dose chemotherapy with hematopoietic cell transplantation. It has been reported to occur in 5% to 55% of patients undergoing myeloablative hematopoietic cell transplantation. The major risk factor for the development of sinusoidal obstructive syndrome or veno-occlusive disease is high-dose chemotherapy associated with myeloablative transplants. Preparative regimens including busulfan, cyclophosphamide, and/or total body irradiation greater than 13.2 GY have been associated with higher sinusoidal obstructive syndrome or veno-occlusive disease rates. Patient-specific factors such as older age, impaired performance status, and advanced disease have also been reported to increase sinusoidal obstructive syndrome or veno-occlusive disease risk. Although the exact pathophysiology underlying the development of sinusoidal obstructive syndrome or veno-occlusive disease is not fully understood, it is known that damage to the sinusoidal endothelial cells in the liver is the initial insult which initiates the process. Damage continues and leads to sloughing of the endothelial lining of the sinusoids, ultimately resulting in embolism and obstruction of sinusoidal flow. This obstruction of flow within the liver contributes to post-sinusoidal portal hypertension and worsening liver dysfunction, usually manifested by increased bilirubin and ascites. My next question to you reads: what signs and symptoms in KTM are consistent with a diagnosis of sinusoidal obstruction syndrome or veno-occlusive disease? The initial signs and symptoms of sinusoidal obstruction syndrome of veno-occlusive disease can occur anytime within the first 15 to 30 days post-transplant. Insidious weight gain exceeding 5% of baseline may be one of the first manifestations of impending sinusoidal obstruction syndrome of veno-occlusive disease, occurring in more than 90% of patients within 3 to 6 days after marrow infusion. Weight gain is caused by sodium and water retention, as evidenced by decreased renal sodium excretion. New onset of transfusion-refractory thrombocytopenia may also be an early sign of impending sinusoidal obstruction syndrome of veno-occlusive disease. Hyperbilirubinemia, which also occurs in virtually all patients, follows the onset of weight gain and usually appears within 10 days after hematopoietic stem cell infusion. Other liver function test abnormalities usually occur after hyperbilirubinemia and include elevations in AST and alkaline phosphatase. Ascites, right upper quadrant pain, and encephalopathy lag behind changes in liver function tests and develop within 10 to 15 days after infusion of hematopoietic stem cells. Although liver biopsy is the gold standard for diagnosis of sinusoidal obstruction syndrome of veno-occlusive disease, its use is limited due to the risk of bleeding during the procedure. Other non-invasive criteria have been developed to help diagnosis sinusoidal obstruction syndrome of veno-occlusive disease after hematopoietic cell transplantation. Two sets of clinical criteria call for an evaluation of hyperbilirubinemia, ascites or weight gain, and right upper quadrant pain not attributable to other causes such as medications, acute graft versus host disease, or infection. Along with these criteria, ultrasound may be useful in determining whether there is reversed hepatic venous flow and to confirm ascites and/or hepatomegaly. My next questions to you read: what is the likelihood that KTM will recover from her sinusoidal obstruction syndrome of veno-occlusive disease? How should she be treated? There is no standard treatment for sinusoidal obstruction syndrome of veno-occlusive disease, although many patients with sinusoidal obstruction syndrome of veno-occlusive disease, that is 70% to 85%, spontaneously recover. Preventive measures look to control patient risk factors, and pharmacologic prevention strategies have also been used. Patient-specific risk factors are often not reversible. However, selection of appropriate preparative regimens such as non-myeloablative regimens, avoidance of concomitant hepatotoxic drugs, use of fractionated total body irradiation, and the use of adaptive busulfan dosing may reduce risk. Preventive medications have also been investigated. The use of prophylactic heparin has shown varied results in clinical trials. Therefore, its use is still controversial. The data for the use of ursodeoxycholic acid are also inconclusive. However, some trials have shown a benefit in reducing the incidence of sinusoidal obstruction syndrome of veno-occlusive disease with its use. According to one trial, patients who received ursodeoxycholic acid were shown to have decreased hepatotoxicity, less acute graft versus host disease, and better survival. Other treatments consist of supportive care measures such as management of sodium and water balance, and paracentesis, in severe cases, for ascites that is associated with pain and pulmonary compromise. Volume expanders such as albumin and colloids may be used to maintain intravascular volume, spironolactone may be used to minimize extravascular fluid accumulation, and protein restriction and lactulose may be used if encephalopathy develops. Unfortunately, improved outcomes with these measures have not been confirmed. In patients with severe sinusoidal obstruction syndrome of veno-occlusive disease and multi-organ failure, available treatment options are limited. Thrombolytic therapy with recombinant human tissue plasminogen activator and heparin have had mixed results in terms of efficacy and can cause fatal intracerebral or pulmonary bleeding. Defibrotide, an investigational drug, has shown promising results in the treatment of sinusoidal obstruction syndrome of veno-occlusive disease. Defibrotide, a ribonucleotide, has antithrombotic, anti-ischemic, and thrombolytic activity without producing significant systemic anticoagulation. In a compassionate use trial of 88 patients with severe sinusoidal obstruction syndrome of veno-occlusive disease and associated organ dysfunction, 36% of patients had complete resolution of sinusoidal obstruction syndrome of veno-occlusive disease and 35% survived past day 100 after hematopoietic cell transplantation. Although the use of defibrotide in treating sinusoidal obstruction syndrome of veno-occlusive disease appears to be effective, little is known about whether prophylactic defibrotide could be beneficial in high-risk patients. Corbacciolu and colleagues explored this question in children with malignant infantile osteopetrosis undergoing stem cell transplantation. Previously 7 out of 11 or 63.6%, n equal to 20, of the children in their center between 1996 and 2001 experienced sinusoidal obstruction syndrome of veno-occlusive disease. Defibrotide prophylaxis was initiated in 9 consecutive patients between 2001 and 2005, and in this group, 1 out of 9, that is 11.1%, was diagnosed with moderate sinusoidal obstruction syndrome of veno-occlusive disease, suggesting a significant benefit from prophylactic defibrotide. To further explore this question, a U.S. National Institutes of Health-sponsored prospective randomized trial has been undertaken to answer the question as to whether prophylactic defibrotide is superior to therapeutic defibrotide in children at high risk for experiencing sinusoidal obstruction syndrome of veno-occlusive disease during stem cell transplantation. Because KTM does not meet the criteria for severe sinusoidal obstruction syndrome of veno-occlusive disease, she should be managed conservatively with fluid restriction and spironolactone for fluid diuresis. Her signs and symptoms should resolve during the next 2 weeks. Because she has mild sinusoidal obstruction syndrome of veno-occlusive disease, she is likely to recover completely without sequelae. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 478.